relax, I request Dr. Mahesh, my co-chair, to start his first talk, Visual Field's Essential Tool of Neuro-Ophthalmologist. Dr. Mahesh is a senior consultant and prolific teacher, heads the Aravind Eye Hospital Neuro-Ophthalmology Department.
Thank you, Dr. Ambiga. So, good afternoon all, and thank you for attending this course. So, the topic given to me is visual field testing, the importance of visual field testing in neuro-ophthalmology, and the time given is some 6 to 7 minutes. So, I'll have to summarize the most important findings and most important points here. So visual fields is one of the most important visual sensory function, the other being visual acuity, color vision, and contrast sensitivity. So this figure is for the postgraduates. It's a hill of vision surrounded by a sea of blindness, and this requires hill of vision. I hope all the postgraduates remember this. And the objectives of this presentation is to highlight the various field testing strategies in neuro-ophthalmic diseases. And to some extent, I'll be covering the visual field effects in neuro-ophthalmic diseases. So the objectives, the value of fields in neuro-ophthalmology lies in localizing the lesion, lateralizing the lesion to some extent if possible, to the right or left side, purely based on the visual fields, as well as to some extent, unlike glaucoma, where every visual field is done for a quantitation and seeing for progression or regression by quantifying with numbers, to a large extent in neuro-ophthalmology, we just do a quality examination rather than quantification. But in certain instances, like following up a case of a pseudotumor cerebri, idiopathic intracranial hypertension with papilledema, we need to track the progression of the visual fields, whether it's regressing or getting better. Similarly, an optic neuropathy secondary to a thyroid eye disease or a tumor progression or regression. For example, a pituitary adenoma being followed up with a medical treatment, the endocrinologist might want to know whether the tumor is regressing and whether the optic chiasm is getting released by the tumor. And here quantification is important in neuro-ophthalmology. Broadly, the types of visual field testings are confrontation field testing, Amsler grid, kinetic and static perimetry, and confrontation is not to be underestimated, and finger counting to the right and left of fixation, a red target testing with specific red color objects, because certain optic nerve functions are very sensitive for red targets. And together with all these testings, confrontation will pick up more than 75% of neurological field effects. So its importance cannot be overemphasized. It's extremely important to do a confrontation field testing. Next is Amsler grid. So the traditional understanding is an Amsler grid is something to do with the macula, something to do with the central fixation points. But we need to remember that certain optic nerve dysfunctions like a toxic optic neuropathy or an optic neuritis can impinge on the papillomacular bundle, which deals with the central vision. And so in specific instances, we need to do the Amsler grid also in optic nerve dysfunctions to look for a central vision loss. Kinetic perimetry, the Goldman has largely become out of vogue now for want of the machines availability and the maintenance of it, and hardly very few institutes still maintain it. And if it is available, it is of very much value, but the downside is that it is a time consuming test and requires a very trained perimetrist to undertake this test, and because of these disadvantages it has fallen out of vogue. And a simple Jerem screen or a tangent screen will still holds good in some institutes. Central 30 degrees is a good testing strategy in Jerem screen. In automated perimetry, the pattern than light sensitivity, the pattern of visual field effects is more important, and it is denoted by the grayscale. Even though the glaucomatologists may not like the grayscale, in neuro-ophthalmology to a large extent the grayscale is good enough to test these field tests to these neurological fields like this one. We have the grayscale, which grossly gives the field effect of a right homonymous inferior quadrant anopia. And we need to place a neurological field side by side. Unlike glaucoma fields which are seen individually, neurological fields need to be placed side by side because we are dealing with a bilateral problem because of the chiasm and the retrochiasmal field defects. Place the right on the right side and the left on the left side as the patient sees it. As the patient sees it, and that's the right way to hold these field charts. And apart from that, we do most instances we do a central 30-2 because we need to see the peripheral junctional scotomas. A 30-2 is preferred for most neurological field defects. And in some instances where the patient may find it difficult to cooperate, a wheelchair patient, a neurological hemiplegic patient may not be able to sit for the visual field testing for a prolonged duration, then we can perhaps do a supra-threshold full field 120-point screening test can also be employed, and to a large extent this also will give the neurological field defects. You can see here a bilateral bitemporal heminopic field defect here picked up only by the 120 supra-threshold field testing. So the other field defects which we see neurological field defects are the homonymous field defects, and if you see an incongruous field defect like this, in this instance a left homonymous incongruous field defects. For the postgraduates, if anybody is here, remember that an incongruous defect is indicative of an optic tract lesion. Optic tract lesion, incongruous, and the more the posterior the lesions are, it becomes more congruous. But there is a caveat here: if this field defect becomes complete, meaning becomes complete homonymous hemianopia, then it is non-localizing. We cannot say that it is not arising from the optic tract. It could still be arising in the optic tract. To begin with, it could have been incongruous, and once it has become complete, it's difficult to say whether it's in the optic tract or in the radiation. So if it is an incomplete lesion, we can to a large extent say that whether it's congruous or incongruous. So the other field defects are a temporal lobe lesion here, such as this abscess pressing on the Mahesh lobe, producing what is called as a congruous superior homonymous quadrant anopia. For PGs who are unable to remember the temporal lobe is below, so it will produce a superior quadrant anopia or a pie in the sky. And similarly, for the optic radiation in the parietal lesions, such as this one, which is a meningioma in the parietal lobe, you may have a pie in the floor appearance, pie in the four field defects, which is an inferior quadrant anopia, because here the fibers are superior in the parietal lobe and may correspondingly present a inferior field defect. I'm just summarizing last few slides. Remember, the occipital lobe lesions always pair the macula, which is the central 10 degrees. You all know the reason: bilateral supply, posterior cerebral artery, middle cerebral artery, as well as a large macular representation. So a wedge-shaped defect, and a bilateral here, it's a bilateral occipital lobe lesion. There is a small field defect called as a temporal crescent if there is an infarct in the anterior part of the occipital cortex where this temporal field does not have a pair. Remember that the temporal field is larger than the nasal field, so a small amount of a temporal field cannot have a pair on the corresponding nasal side, and this is called as a temporal crescent. And this is the only field defect retrochiasmally which is unilateral. And this happens when this part, anterior part of the occipital lobe is involved. So there is a place for 10-2 also in the neurological field defects. I told you these neurological field defects occasionally can cause central field defects like toxic optic neuropathies like ethambutol, chloroquine, LHON, Lebus, or an optic neuritis. Central or centrocecal scotoma can be specifically picked up by 10-2 central field defects. So in summary, we need to do confrontation fields, Amsler grid. A Jerem screen may be employed for central scotomas, homonymous field defects. A Goldman is ideal if it is available. And in Humphrey fields, 10-2 for central defects, 25-2 for most homonymous bitemporal field defects or homonymous field defects. And 120 full field tests can be done in a supra-threshold manner for quick screening tests in difficult patients who are unable to cooperate. Thank you for your attention.
Thank you, Dr. Mahesh. An excellent overview of fields, which actually form one of the most essential investigations in neuro-ophthalmology, probably just after vision and pupils. So these trio actually give us a lot of information and are a must for every patient.